Good afternoon, good morning, good evening, wherever you may be joining me from. Welcome. My name is Amanda Harley and I am the Paediatric Sepsis Clinical Nurse Consultant over here in Queensland in Australia. For some of you, that's a very long way away, and I certainly feel a very long way away sometimes. Now, thank you for joining me this afternoon. I'm going to speak to you about the role of parents or carers in sepsis recognition and management, and what can they do to assist you and to assist their own child when they present to your department. So when we think about recognising the child with sepsis, many institutions, and it's certainly recommended from the Surviving Sepsis Campaign guidelines, they recommend that you have a systematic screening tool in place to assist in that early recognition. Now, the difficulties with that and the challenges are that paediatric sepsis is incredibly challenging to recognise in the early phases. If it was easy, we wouldn't need these screening tools. But sometimes it's a myriad of signs or symptoms that I like to think of it as a puzzle when they're combined, or we ask different questions, we glean different information, we think outside the box. That sometimes can tell the story of paediatric sepsis and allow us to recognise it earlier instead of waiting until your patient in front of you has very obvious septic shock, because we know from that point the trajectory of rapid deterioration and higher mortality is the concern. So the key really is early recognition and stopping that progression onto septic shock if we can indeed recognise it early and the patient's presented to your department early enough. So our aim is to recognise and to create opportunities to manage paediatric sepsis early. But why is it so challenging? Challenges are around that infection is really common in children. Most children go through childhood and get several infections. Now, many of them are going to be simple, uncomplicated infections, simple viruses that resolve on their own after days of potentially crying, irritability, sleepless nights for the parents. May not seem easy at the time, but essentially they're simple infections. We do know, though, some simple infections then progress, and for some reason we have this dysregulated host response to the infection, and they become complicated infections where we talk about sepsis. We talk about sepsis in terms of organ dysfunction in the presence of an infection due to this dysregulated host response to infection. So the challenges are that sepsis is uncommon. Late sepsis and septic shock that I spoke about is more easy to recognise, but the challenges are that then there's delayed treatment, the ship is sailing away from the dock already, and there's poorer outcomes because the child is already in that phase where you are having potential cardiovascular dysfunction and outcomes are poorer. If we can get it early and recognise it earlier when the child has not deteriorated rapidly and they're not septically shocked, then we know that we can have better outcomes. But the challenges are, how do you distinguish the child with simple infection that has a temperature, that has a fast heart rate, that has a fast breathing, that may look a little bit pale, versus one that has sepsis that may very well present with very similar symptoms, but then deteriorates very quickly. It's sometimes akin to finding the needle in the haystack. So the first important thing to really ask, and this is one puzzle piece we can certainly use, is asking, would this be sepsis? When you're assessing children, have that in your mind, rule it out early instead of ruling it out late. Rule it in early instead of ruling it in late when the child has that septic shock. So certainly reviewing sentinel cases, we think, had that question been raised earlier in the child that was irritable, had a fast heart rate, looked a bit average, just didn't look quite right, had sepsis been ruled in a bit earlier or even asked the question, then outcomes may have been very different. When we talk about sentinel cases, this is a report that was done from the Paediatric Patient Safety Review Project over here in Queensland. Now, I just want to draw your attention to what a sentinel event, SAC1 event is, and it's called the Severity Access Code, where permanent disability or harm or death has occurred that could have been preventable. That was possibly preventable. That is how we coin a SAC1 event over here. Now, from the events that were reported in Queensland, 10 out of 14 incidences were attributed to sepsis. When we break that down even further, we see that 7 of those patients actually died, but 8 of them had a delayed diagnosis. The 8 had a delayed diagnosis where sepsis was not diagnosed until very late, and we know that these children had permanent harm, disability, or death occur. So again, we see that there is quite a challenge with that early recognition, and one actually had a completely misdiagnosis entirely. Now, there are many themes that can come from this, and when we look at when they looked at the theming around those sentinel events, the one I really want to point out to you today, because this is our focus point, is the parental carer concerns were not addressed or recognised. Now, what does that actually mean for us? It means that, again, parents are another key part of that puzzle. We learn it in university. We learn it in courses. We hear it again and again and again, that the parent is the expert of their child. But that obviously can be very challenging to, again, distinguish between parents that are concerned, who come to emergency departments or come to hospitals because they're concerned for their child. Obviously, that's why they're there, versus the ones that can articulate or tell you that just something is not right. And we'll go into that a little bit later. But this is a really simple thing that we can utilize in our clinical practice to drill down on and think and ask further questions around, well, why is the parent concerned? We don't have to wait on any pathology or any tests. Purely it's having a conversation with that patient parent in front of you to find out what it is that they're concerned about and what does that concern mean to them. They may very well say that their child's been sick several times before, but this illness is different. So key things like that are certainly red flags. Now, importantly, sepsis starts in the community, and therefore the decision and timing of when parents actually seek medical care is likely to contribute to their severity upon presentation and certainly their sepsis-related outcomes. But interesting, this discussion paper really looked at the multitude of pillars and the complete patient journey that occurs from the pre-hospital environment all the way up to post-sepsis care. Again, obviously, we are focusing on that community and that parental recognition phase. And despite the fact that sepsis commonly starts at home, the role of recognition of sepsis by those parents to improve the accuracy of that early sepsis diagnosis really doesn't have a lot of research behind it and certainly big research studies. But we do know, as we've said, we learn it in university, we're taught it in courses, we're taught it in our new graduate years, we're taught it on our wards when we learn about paediatrics in general. Parents are the expert. And certainly for sepsis, a lot of national sepsis quality initiatives have embedded that parental concern as a key part of that sepsis when thinking about sepsis screening and that early recognition. We did a literature review a couple of years ago now that really looked at the role of that parental concern in the recognition of sepsis in children. And we found that only one article prospectively assessed the diagnostic performance of parental concern in children. It did, however, indicate that there was a high positive and negative likelihood ratio for sepsis or meningitis in the presence of parental concern. And again, statements were made around this illness is different. And it indeed had a positive association with sepsis diagnosis. So again, it really does raise those questions. What are the roles of parental concern? A few of the other papers that we found, although there was only one assessing that diagnostic accuracy, quite a few others looked at and were reporting on the role of parental concern as a sign of assisting in that recognition of sepsis. And that was in 4 studies that reported on other original data. And then there were 6 reviews that, again, commented on parental concern, which was listed as a factor upon that diagnosis of sepsis. So you can check out those papers, and that certainly breaks it down into a lot more detail for you. We recently completed a study ourselves that really did look at the diagnosis of paediatric sepsis in emergency departments and involving those parents and utilising them as a diagnostic tool to delve a little bit further, and was it associated with a sepsis diagnosis. And that paper is currently under review, and the results will be out hopefully soon. So those are two papers that I'm speaking about, and the original data of the study that we've recently finished, will be available soon. But I really want you to think about what key role do those parents play, and how can you use them in your practice wherever you are, low, middle, high income countries, to really add that tool to your toolkit. Even involving them in that escalation is certainly an area that's moving forward a lot, and escalation of that concern to get early medical review, to get early reassessment, because they're going to be with their child the whole time during that department. Now, I could talk about that quite a lot, but I think the most valuable person to hear from is a family member herself. And I'd just like you to introduce you to the wonderful Mary, who's got a few things that she'd like to share with you.
I lost my son, Preston James, on the 10th of August, 2003, when he was 2.5 years old. Preston had been suffering pneumonia from a simple virus, which caused an acute lung injury, then allowing a secondary bacterium to invade his body, causing overwhelming sepsis. I had made several trips to the hospital leading up to the week before he died, only to be sent back home with my critically ill son. On the final trip, my son's lung had already collapsed, and he went to PICU, only to die a few short hours later. The cause of death was identified as complications with pneumonia and not sepsis at the time. While I felt the emergency department staff was caring, it was never acknowledged that I had been there several times, and no one ever looked deeper into what was going on. I remember saying that I thought he had leukemia or something terrible. It was the only way for me to articulate and explain that I thought something more sinister was happening. At that point, I would have liked the nurses or the attending staff to ask me why I thought that, and maybe that would have assisted their diagnosis, as I would have been able to say things like, he wasn't eating, he won't stop moaning, he was so lethargic, he was getting worse but not better. I would like the staff to listen to what the parent is saying, understand that we're not medically trained, but try to speak to us and hear us from the perspective of a person, a lay person, a parent. If someone is sent home from hospital, let them know it's okay to come back, that we are worried and concerned. Give them a checklist of things to look out for. If they present again, look deeper and ask deeper questions. We are actually relying on you and putting profound trust in you for answers. And we're relying on you and your training and your instinct.
Thank you, Mary. So that very well summarises that parental concern, and you can hear by her saying, I thought my son had leukemia. So that's not saying I thought my son had sepsis, because we know that a lot of people don't know what sepsis is in the community. But leukemia is a severe, scary, concerning thing that a lot of the community know about. So that in itself articulates what her concern was, that something was seriously not right with her child. Now, speaking of institutional screening tools that assist with that early recognition, in Queensland, we certainly include that parental concern and provide staff with education around what that actually means. And it's actually had a really good education effect. So a couple of quotes from clinicians are there. They actually understand what it means. It's that something is not right with my child. These are the reasons why. And that they listen to the concern more seriously. We also have a leaflet, which I'll show you on the next slide, because, again, knowledge is power. So we know in sepsis, as we spoke about, that early recognition can be incredibly challenging. Lots of children get discharged home and will be completely fine. However, a small proportion will come back with sepsis after they have been discharged with what seemingly was a simple infection. Now, it's not necessarily that someone made the incorrect diagnosis, It's just that it was too early in the trajectory of that illness for it to declare itself. So really important is that safety netting. So just like we do for head injuries, if a child's had a concussion, if they've hit their head, we give them advice to come back if something changes. The same goes for sepsis. Some information around what it is, some concerning signs and features that may prompt a return. And then a checklist is also helpful. So the parent can come back and go, these are the things that I'm concerned about and the things that have changed since I was last seen. We know that representation of health services is another red flag for that sepsis diagnosis. Parents have also said if someone had just mentioned sepsis to me or I knew it was a thing, something I needed to be concerned about, then I feel the outcome for my child would have been very different. Again, that knowledge is power, and this certainly will help with that early recognition at home and highlights the role that the parent will play that we as health professionals cannot once they're discharged from our care. There's a lot of things recently going on around public awareness and highlighting the importance of that. So we know that parental education for reducing infant mortality due to infections in low-income settings has been beneficial. So it's reduced that mortality. Yet we don't really know at this stage yet what role the parental assessment in discriminating the children with a mild infection that we spoke of to those with sepsis. More research really needs to occur in this space to see whether the capacity of parents to actually help us differentiate between those common febrile illnesses versus improving that diagnostic accuracy of a sepsis and using them as an assessment tool. We know they're important, but hard research and more evidence needs to be developed around that. The final thing I want to talk to you about is once a child has a diagnosis of sepsis, it's really important to support families and they're a key part of that patient recovery and journey forward. I just want to share with you some resources that are available on the Pediatric Sepsis Program webpage. That is, you can scan any of those QR codes and it will take you there. But it's to help families as well understand what sepsis is so they can raise that awareness in their own community. They feel like they can speak to people about it and have that shared mentality around what sepsis is. Everyone knows what a heart attack is. Everyone knows what a stroke is, generally speaking. But mention the word sepsis and families are isolated because their neighbour or their friends don't understand what that is, yet they've been through potentially months of turmoil and trauma. And we know that the journey for that child does not finish when they get discharged from the hospital. So in Australia, in Queensland, we have a Queensland Family Support Network that our social workers have developed, as well as peer mentor program. Anyone can access these videos though, and they're little snippets from different stages of sepsis that our families have designed to really get that increased awareness for clinicians, but also primarily for families to understand what those key journeys are. As a clinician, we also have lots of information around sepsis, lots of education resources, lots of things that are downloadable and accessible. So again, anyone can access that, and you can just log on over here to this page here, and hopefully that will be of benefit for you in your department. Finally, just a brief quick mention, although I've spoken about the limitations in the research in this space, there are certainly more movements forward in the last few years around really including families and parents in the care of paediatrics and using their knowledge and their input and supporting them afterwards. So in Australia, we've recently released a national clinical care standard for sepsis, and one of the key quality statements is around providing that parental and carer information and support for their child or adult that has sepsis. It's becoming a standard, and in many other states and countries, this is already in place. So finally, there is more information needed to specifically analyse the benefit of providing education, raising awareness, seeing what the unique role parents play as experts of their child. It may have the potential to enhance that diagnostic performance of screening for sepsis, and really is that rule-in approach early and not waiting for a septic shock where we're pretty comfortable that the child is very obviously has septic shock, we can recognise that early. So this focuses really on that earlier phases, or the phases where the child's looking unstable, looking unwell, but that shock isn't recognised early because they're compensating. So hopefully this forms a key part of your puzzle moving forward. It's a really easy tool to implement, using that parent, using that carer to help with your assessment. And hopefully in the future, well, we already are seeing that improvements are being made, and certainly community awareness is at the forefront. And of course, this is why we do what we do. I'd just like to pay my respects and my appreciation to all our families that we work with. And as clinicians, we certainly have them at the heart of what we do, and we really want to improve the care for them. Thank you very much. I'd just like to acknowledge my team that I work with for all the wonderful work that they do as we aim to improve outcomes for children. Thank you.